for me, really, it's a massive privilege if I look back a year or two to where we've come to today, and being able to sit amongst these people and ask them questions, and annoy them with all of my emails of changing dates, etc. So thank you all for your patience and for coming through. I know some of you had to travel this evening as well. With this talk, I was very interested to touch upon the practicalities of psychedelic-assisted therapy. I think we talk a lot about what could happen, all of the drugs that are out there, but we lose sight maybe of the care delivery aspect. And so today I really wanted to touch on some tangible research and experience about how these sorts of therapies can work, how they developed and came about, including from traditional cultures, as well as specific types of therapy and integrations that are available now and will be available in the future. So firstly, I would love to introduce Dr. Sara Tai, who has very kindly joined us from Manchester this evening. I will probably butcher all of these introductions, so I've just picked the highlights that I think really stand out for me and for the people around us. Dr. Sara Tai is a senior lecturer in clinical psychology at Manchester University, and she is a consultant in clinical psychology at Cheadle Royal Hospital and Greater Manchester. Sara is a highly experienced practitioner and supervisor of transdiagnostic approaches to mental health. And among many other things, Sara was part of designing the therapy and delivery model for Compass Pathways program for psilocybin, which many of you know well, and we've had a very interesting couple of weeks there. Sara is really training the trainers in this field, and it's an honor to have you on stage. Thank you very much. Dr. Ben Sessa, Senior Research Fellow at Bristol, Cardiff, and Imperial College London universities, where he is focused on an incredibly interesting part of psychology, which for me is the developmental trajectory from child maltreatment through to adult mental health disorders. Ben is currently conducting the UK's first clinical trials in MDMA-assisted therapy for the treatment of PTSD and alcohol use disorder. He has also, I believe, and correct me if I'm wrong, I think you were the first person to get a proper dose of psilocybin since the 60s from Professor David Nutt, right? So yeah, that is an achievement in and of itself. And in addition to that, Ben's groundbreaking research and protocols in psychedelic-assisted therapy. He has been a child and adolescent psychiatrist for the past 20 years. He's the author of a number of books. One of my favorites, Psychedelic Renaissance, which is a fantastic Bible for the space and clinical research up to this date. I really recommend. And Ben has co-founded the Breaking Convention, and I think what we mostly know him for is being the Chief Medical Officer of Awaken Life Sciences, a company we at Neo Kuma know well. Last but not least, Dr. Simon Ruffell, who currently works as a psychiatrist at Maudsley Hospital in South London and is a clinical research fellow at King's College London, looking at the use of psilocybin in treatment-resistant depression. Simon's main focus, however, seems to be ayahuasca, and Simon has spent the last 5 years conducting research into its use in the Peruvian Amazon, as well as the associated mental health outcomes. One of the things that astounded me about Simon is he self-funded his initial research in this space, and is really an amazing human being. Simon has worked with child soldiers in northern Uganda and commits a lot of his time to nonprofits in this space. Sadly, we will be losing him to Australia in the coming months, but he will be continuing his amazing work, and I hope you can share some of that later on. So with that, I guess, Simon, I might as well start with you, since you're kind of starting at the beginning with these traditions and treatments. I wonder if you could just tell us a little bit about what you're doing with ayahuasca, what you've done over the past 5 years. It would be really great if you could give us a layman's terms explanation of what ayahuasca is and how these traditions have helped inform modern psychedelic-assisted therapy.
Sure. Brilliant. Thanks very much, Sean. My name's Simon, and I've spent the last 6-7 years now researching ayahuasca based in the Amazon rainforest. So for those of you who don't know what ayahuasca is, very simply put, it's a psychedelic, it's a traditional brew that's made from 2 different plants in the Amazon rainforest. It's used by traditional communities to try and communicate with in different dimensions and also for healing. What we've been doing over the last 7 years now is trying to look at how this affects mental health outcomes. So we started off in the very early stages, looking at the effects of ayahuasca on personality, and that's the study that we self-funded. Probably unsurprisingly, about 7 years ago, nobody actually wanted to fund this kind of research into ayahuasca, but me and my colleagues really believed in it, and so we did this pilot study. And we found in that study that there were significant decreases in how neurotic participants were. So that's whether they're anxious, very simply put. And on the basis of that, we did manage to get some funding from the Medical Research Council, which is part of the UK government. And this allowed us to start doing research looking at the more common mental health conditions that ayahuasca might have an impact on. So we saw that ayahuasca could be effective, or our results suggested it could be effective, in treating depression and anxiety, as well as traumatic memories from childhood. And this was actually the first study ever to look at any psychedelic and its effects on DNA. And so we were collecting saliva samples and looking at the way the DNA expression changed, which is a field called epigenetics. The reason that I'm actually moving to Australia is that we're now starting to look at ayahuasca out of the jungle, and we're doing a randomized control trial. So that's a lab-based trial looking at ayahuasca based in Melbourne, at the University of Melbourne. And if we get positive results, then this opens up the possibility that ayahuasca could be prescribed by medical doctors in the future, or at least a form of ayahuasca. So that's why I'm moving to Australia, to continue that, and also to continue the research that we've been doing in the Peruvian Amazon. I think the rest of that question, Sean, was...
I mean, I could dive in there and I suppose follow on. And forgive me if I'm incorrect, but traditional ayahuasca ceremonies are in a group setting, most notably associated with chants, songs, various other aspects, adjuncts to the drug. Really interesting on your thoughts of that and how it contributes to the healing process, and also how we can potentially learn from those sorts of practices in our more Western clinical model of kind of one patient, one clinician.
Yeah, that's a really interesting one. I think firstly, the way that we're looking at psychedelics in clinical trials is already using lots of influences from traditional cultures. So the whole kind of creating a ceremonial space, the ceremony in general, the music, all of it, that comes from traditional cultures. And when I say ceremony, I'm using that broadly, because obviously in the trials that we've been doing, like at Manchester and Bristol, we know we don't have a shaman there, but what we have instead is a psychotherapist or a psychiatrist, and it's this safe container with music to take you on this journey. I think when it comes to ayahuasca, it's a slightly different one, because ayahuasca works in very different ways depending on the lens through which you view it. So I'm particularly interested to see whether or not the results that we're going to get in Australia are going to be as good as the results that we've got based in the Amazon. Because it's a very Western way of thinking, to think that it's just the chemical that's having the effect, rather than anything else. I think it's quite easy for scientists to say, well, obviously it's the chemical, but no, do we know that? No, maybe. So what role does the ceremony have? I think it has a very large role, but I'm not quite sure how far that extends.
Yeah.
Can I briefly interrupt?
No, please.
It's very rude. How does the protocol differ from, the MDMA within the, number of sessions? You have that number of sessions. Is it just one of the ayahuasca, or is there a number of them?
So we're going to go for three sessions, 1 week apart. And it's interesting as well, so we were picking up on the importance of the group. So what we're trying to do in the trial in Australia is to have lots of group aspects, which is something that hasn't been done yet. There was one group study that was done at King's, but we're trying to not do group dosing at the moment, but have lots of group preparation and lots of group integration. So when people have been dosed, we're going to bring them together to do these formal group integration sessions. Because as Sean said, occasionally you get people in the jungle who drink ayahuasca individually, but that's not normally the case. It's always done in community. In fact, it'd be kind of weird to do a one-on-one ceremony. People will question why wouldn't you have that community support? So that's something that we're trying to bring into those trials in Australia, is that feeling of community support as well.
Yeah, and I think when we look at Leo Roseman's research with Palestinians and Israelis, I think there's a big case for potential with group therapy, at least from a conflict resolution standpoint. So thank you very much, and thank you for interrupting. Another, I suppose, final question on this is really, Sarah, for you. Your work has been so instrumental in really showing how the drug alone will never get us to where we want to be. How does the use of psychedelics in assisted therapy, how are you creating frameworks for the use of these drugs? And I suppose, tacking on to Nikki's question as well, how do those frameworks differ depending on the compound that you're working with?
So when you say frameworks, you're meaning how do we understand what's happening in psilocybin, or the mechanism by which this effect is?
I think I'm very interested in your sort of breakdown of three, which is preparation, dosing, and then integration. Integration we can touch on in a little while, but I'm very interested in how you prepare and then dose these different and create the protocols around those for various compounds.
So I suppose for me, in understanding what we're trying to achieve in psilocybin-assisted therapy, we're really creating an unusual experience for someone. And then creating conditions where they are able to focus on experiences that they might otherwise not be able to attend to. It could be that those experiences are very challenging, so it's difficult to stay focused on that. It might be the experiences are so difficult they want to avoid it. There's a whole number of reasons why people find it hard to stay focused on an experience. And of course, in order to find resolutions with difficult experiences, you kind of have to pay attention to them for a while. So some people go to therapy, and with all best intent, it's really hard work. And this may be a way of helping people be able to look at those experiences. And because what they're going through is so unusual, it forces them to look at it from different perspectives. And that potentially generates new insights. So, of course, the three phases of psilocybin therapy, assisted therapy, when preparing somebody for that, you're really preparing them to be able to start to look internally at what's going on and, be able to sit with some uncomfortable emotions and learn how to think from different perspectives. And then, of course, when you dose them, you're trying to create a situation where they're as safe as possible to be able to encounter that quite dramatic, quite unusual experience. And the more they're able to tolerate doing that, the greater chance there is they will be able to think about things in more, flexible ways and look at it from different perspectives. And then, of course, in integration, you're bringing all of that together and saying, let's use those experiences to really try and piece them together, think about it, problem solve, and that's where we think, the effects then may occur. So it's really important that all three of those phases are done properly and in the safest way possible.
Thank you, and forgive my simple question. Just to follow on from that, I think one of the interesting things about psychedelics, especially also Ben in your work, and you mentioned a lot of the people, I believe 90% of the people you work with have some other issue or psychiatric condition, right? Which I think you said 2 out of the 8 child traumas 90% of your patients have. And that led me to begin thinking about comorbidities. And how are you thinking about comorbidities when you're designing these protocols for patients? And it's a question really for both of you, and also Simon, any input from you as well from the ayahuasca side. I mean, it's a very different type of treatment, but it requires a lot of preparation. Not many people want to go that deep, and so by all means jump in, Ben, if you don't mind.
I'm one of those kinds of psychiatrists that doesn't really believe in diagnosis anyway. We've spent the last 50 years of this top-down biological model categorizing people into pigeonholes. People don't go to see their doctor with a psychiatric diagnosis or a problem. They go with a life event and a functional impairment. They go because they've lost their work, because they can't see their children, because their partner's left them. And so instead we pigeonhole them into these groups and categories. So as you mentioned in the introduction for me, as a child psychiatrist, I take this very developmental stance. I can't help banging on about attachment theory because it is the strongest effect size in all of psychiatry. If you hurt a child, you create a damaged adult with hugely susceptible increased vulnerability to mental health problems and particularly addictions and other things. But I almost see the different end phenotypes of the different disorders as fruiting mushrooms. And underneath is the mycelium of trauma. And if you traumatize a child, which is the mycelium, any individual, they may get a personality disorder, they may get depression, they may get an eating disorder, they may get anxiety disorder, they may get PTSD. It doesn't really matter what the end fruiting body is called. And it certainly shouldn't matter what we treat them with. And we pigeonhole the pharmacy to go, this is an antidepressant, that's an anxiolytic, this is for, And so what is so lovely about psychedelics is it cuts across all of that. It gets to the root cause. It takes us away from the concept of treating the symptoms of the overlying made-up diagnosis and getting to the root cause of the person. So, and forgive me for straying from your question, nevertheless, when it comes to research, you have to aim at particular diagnoses. You have to call them something and you have to treat them with something. But we're hoping that psychedelics and the renaissance in psychedelics is actually going to be a renaissance in psychiatry, not just psychedelics. It's going to reframe the whole way we look at and conceptualize mental illness and how we approach patients and put them at the center of the care plan so they create their own bespoke care plans driven by what their functional needs are, not what their scores are on a tick sheet.
Thank you. I think if the world could hear that, it would be a better place.
But I certainly don't think I got anywhere near answering the question, did I?
I think maybe Sarah could add a little bit more. I mean, you're very involved in creating these protocols for people. How have you thought about different lengths of times for different drugs, different reactions from different drugs? Obviously, MDMA you speak very highly of. Ben, which hijacks the amygdala and stops the fight or flight response and allows us to dive into issues a little bit deeper. I don't know if I butchered that. But it would be great to understand if there is talk amongst the community that you're in about different protocols and what the different outcomes we're looking for from those are.
I don't think I could have said what Ben just said any better. I mean, I just thoroughly agree with all of the points you just made. And again, one of the really exciting things about psychedelics is, like you just said, it's a real transformation in how we approach interventions. It's a massive shift in how we think about mental health, but also we're going to have to think about shifting away from how we do research. Because a lot of the traditional ways in which we run trials, I'm not sure are the best ways of understanding what's going on here. So you're asking, should we have different drugs for different problems or different protocols? I'm not sure at the end of the day it's going to matter that much because it's the effect for the individual is what is going to vary so much. One drug may benefit a patient much better than another, whereas you take another individual, maybe they need something different. We're really moving towards personalized medicine here, I believe. And sorry if I'm straying from the point too much, just wave, I start to waffle on. But when we do a randomized controlled trial, for example, we're comparing groups of people. We're taking the mean result of what happened. But of course, within one group, you've got some of those people may have had exactly the right drug and just the amount of therapy. Others in that group may have not had enough. And there will be some where it was too much. They didn't need that much. We don't really get an idea by comparing the means of different groups what true individual difference is. And so I think we need to reform and change how we do research quite significantly as well. And sorry, I'm going off the point as well.
That's incredibly interesting, and I think it ties in a lot of with what Simon's doing as well, which thank you is great. I think then my next question's a bit moot, but I will continue anyway. Ben, you've probably worked with more substances on this panel than most. You're working with ketamine right now in your clinic Awaken. You are doing the first clinical trials in MDMA, and you're also looking at psilocybin. Why all three, if there is no kind of winner-takes-all approach? and what for you is going to be the catalyst for this next generation of psychologists, really?
Yeah, I'm in a really fortunate position where I can state on the record that I have taken LSD, psilocybin, DMT, ketamine, and MDMA, because I've taken all of them illegally, most of them injected intravenously, mostly by David Nutt into me. So we had all of those, and we're not actually working with psilocybin at Awaken at this stage. We're working with ketamine and MDMA. I think what's interesting, and Sarah and I were talking about this earlier, in my opinion, take, say, psilocybin, MDMA, and ketamine. Obviously, those are all three very different drugs with very different subjective psychological experiences, and anyone who takes them would be able to tell you that. But in my opinion, in the context of the clinical setting, when they're used together with a therapist, with your preparation sessions, your drug-assisted sessions, your integration sessions, the similarities between those three compounds are much, much greater than their differences. And when it's you alone behind that blindfold with that Brian Eno in your ears on that compound, and as Sarah says, it simply disrupts things. Now, ketamine in one way, psilocybin in another, MDMA in another, but it's really about the non-drug sessions. That's where the work takes place. That's where the talk therapy takes place. The drug is this wonderful catalyst that is essentially an arbitrary peak experience. The issue and the problem with chronic mental health disorders and why they're lifelong is this stuckness. It's the stuck narratives that you form in early childhood. I am useless, I am a failure, I am unlovable, the world is dangerous, people can't be trusted. We learn these things when we're that high, and we never shake them. It's very difficult to shake them. And what these drugs do, all of them, in similar ways, is shake that all up and make anything possible for that few brief, precious hours. But the real skill comes in the preparation sessions, as Sarah says, and particularly the integration sessions. What do you do with that shaken brain as it comes back to normal? How do you recalibrate it? How do you reassign the salience of what's really important in your life and bring the important things up and bring the other dangerous things that you've spent so much time on, bring them down? So going forward, I think that we're going to be in a position, I hope, 5-10 years from now, where we won't be pigeonholing. You'll be able to go into your psychedelic therapy center, like Awaken, and firstly, we're not even going to talk about diagnosis. We're going to talk about what are your functional issues and what do you want to change. And secondly, we'll have a whole smorgasbord of different compounds, some which we may use in combination with one another. So it is difficult because I'm almost talking myself out of a job in front of a bunch of investors here. Because when it comes to this stage that we're at in the field, we absolutely have to focus on diagnoses, we have to focus on compounds, we have to focus on research-driven protocols. But I'm being inspirational in terms of the future because I truly, truly believe that's where we're going and that's going to be the right thing for patients.
Thank you, and I absolutely agree. One of the things, though, that I am concerned about and open for comment from any of you is people with substance use disorders have been excluded from a lot of different treatments. Most of them have, as we've spoken about, some kind of comorbidity. And are these people going to be catered for? We know that ketamine has some substance use potential, abuse potential, and you're obviously digging in with the BEMA study to see what we can do there. So
yeah, I mean, addictions are a very massive public health problem that affects individuals and families and public health systems, and are very hard to treat. No addiction really exists on its own. There's always comorbidities, as there is so often substance misuse with other diagnoses. But yeah, if there's one area of psychiatry that really needs reformation, it's the treatment of addictions. We can split hairs about whether different sorts of addictions require different sorts of treatments, or what the neurobiology is behind, say, pornography and gambling addiction compared to heroin or alcohol addiction, and I'm hoping that David Nutt will do that for you later, because he's much better at the brain side of things. But I think in terms of, yeah, it's certainly an area that requires a massive amount of work. In some ways, it's low-hanging fruit as well, because the outcomes are so poor. I often say this in my talks. We were better at treating alcoholism in the Victorian time programs than we are today. That's appalling after 100 years of modern psychiatry that patients are let down. So it's a massive area that requires a lot of research and some good working protocols that can better patients.
And with that, I would love to turn to you, Simon, and ask you, as we dive into the hot topic of integration, which we have discussed for hours and hours at Neo Kuma. How do we help people better communicate their experiences? I feel that you've mentioned this before, which is, I suppose, our classification of what a drug is, right? Traditional communities would call it a medicine, in your words. And so does that allow them to better communicate their experiences and therefore better integrate them into their daily lives and into their communities? Or have you kind of found that they're quite different concepts?
I mean, it's particularly tricky with ayahuasca, I think, because it is seen as a medicine. I think that at the moment, if people, so when I was based at King's doing the psilocybin trials, there were people who would come on and they would do the trials, but they purposefully wouldn't tell their family, or they try and make sure that no one that they knew that they were on those trials for fear of stigma. And I think that if that's what you're going back to, and you don't have this community of people that you can talk to about your experience, then you're in real trouble. And we see this a lot with ayahuasca. So people have these experiences with ayahuasca or with any psychedelic, and some of them can be so profound and so far out. If you then try and speak to people about that who aren't open to that experience or haven't had that experience, then you can get really, really lost. And so I think there's a real need to normalize the use of these things to allow communities where people can talk about this stuff. I mean, and this is what we're trying to do in our study at Melbourne. This is why we're trying to have these group integration sessions, so that there is a small form of community, so you can talk about what came up without the fear of being judged. And I mean, I know from my own personal experiences with ayahuasca, some of the stuff that comes up, you know, I would never mention that stuff at King's to people that I worked with, to colleagues. They think you were completely insane. And so you're left pondering this kind of thing, which is why it's so important that we have this kind of community so that we can talk about these experiences like the psychedelic community. But if we don't have this open space and we're not referring to these things as drugs, you know, categorized, ayahuasca is in the same group as heroin, you know, if you're going to class it, which is crazy. Then I think it's going to make it really difficult to make the most out of these experiences through integration.
And then kind of diving into integration, the I suppose the biggest piece of it all, right, Sarah? I think you say the drug is just the vehicle, right? And so I would love to kind of talk about integration in two parts, but we'll start with the first part, which is integration as part of the protocol, as part of the psychedelic-assisted therapy. And just to be clear, I don't know if I've properly defined this or any of us have. Psychedelic-assisted therapy is the combination of a psychedelic compound together with talking therapy or traditional therapy of some sort. So it's a combination package, really. And you know, Sarah, found a lot of really interesting things in your discussion about experiential processing and the idea of finding awareness in your own mental state, and that really being the catalyst for change, right? On that, how can we create experiential processing and sustain, which in your words, I believe, and correct me if I'm wrong, sustains the attention on the experiences and allows you to be able to make functional changes? How do we help people sit in that space with integrative care after they've been through quite a traumatic experience, in often cases, weeks of a regime, which may be quite tough? And how do you keep people in that space and continue to keep the focus on those difficult, often traumatic childhood memories?
It's a very good question. And I'd say, first of all, being able to have a space where they feel comfortable and safe to be able to do that. And there may be some days where that's harder for people to achieve, and that might not be a day that's the best day for them to do integration. It's also about the relationship that they have with the therapist. And quite often in psychotherapy, the therapeutic relationship is talked about a lot as being the real vehicle of change. I'm not so sure it's that. It's more the degree to which that therapist is able to help the person feel safe, focus their attention on what's painful and look at it from different perspectives. So it's how much does that therapist help the person to be able to speak openly and honestly without filtering what they're saying. You know, and we all know what that's like when you're in a conversation with someone and there are some friends that you might be able to say something to and other friends that you can't. This is really about creating a space where someone is able to be honest and open. That is going to be different for every single individual. So the therapist needs to be able to operate on some basic principles about being open and curious themselves, but also be able to be extremely flexible to be able to do whatever that particular client in front of them needs. And it's difficult to really just teach people how to do that. It's not a technique-driven thing. It has to be a principles-driven thing. So, you know, you have clear things that you're trying to achieve in therapy, but exactly how you achieve that may vary depending on the person in front of you.
And the die-hard capitalist in me would ask, how does this all scale? That sounds like a lot of work. And if we're going to reach millions?
Well, again, I think one of the ways forward here, which we probably won't see so much in trials, is to give the patient, the client, however we refer to people, as much control as possible. So one of the things I would like to see is greater flexibility in the protocols that we design. There will be some people who may need 10 sessions of integration, but on average, when we look at what happens in psychotherapy, most people are looking around 4 sessions. But we come up with protocols where we say, right, we're going to give you 6 sessions every week. That might not be needed for everyone. If we allow them more control, which is what I hope will happen in clinical practice when we get to that point, people will access what they need. It'll be much more resource efficient, and we will be targeting the individual's needs rather than forcing a set treatment protocol on them, which probably won't be necessary. That will make it more scalable.
Yeah, absolutely. And obviously tools such as VR and digital diagnostics and therapies, and I think interested definitely as well to see how the lines blur between wellness and healthcare over the coming years. But
Could I just comment on the integration? Because going back to the point about the value of integration, I think the concept, going back to this idea that the psychedelic experience itself shakes up the mind and tackles these rigid narratives so much, but it's then how you put it back together, and that has to be driven by the patient and by their, like Sarah says, by their idiosyncratic needs, because it's such a rich learning experience for the patient. And in fact, the psychedelic experience, or indeed the course, is just the platform. It's just the beginning, and it's from that they then build the healing that comes much, much later. And I'll share with you just a brief anecdote. I remember during one of the MDMA sessions, one of the patients, she turned to me and she said, "Ben, is this what love feels like?" And she was very high on MDMA at the time and soaring away. And she said, "Is this what love feels like?" And I thought for a minute, oh, this is an artificial, synthetic, drug-induced experience. This isn't love. Love is all those years of love I had for my family. This isn't real love. And then but before I answered, I then stopped. I thought, hang on, she feels safe. She feels contained. She feels warm. She feels held. She feels cared for. And I said to her, actually, yes, this is what love feels like. This is how it feels. And she said, wow, I had no idea. My whole life I've been scared, I've been hurt, I've been punished, I've been put down, and I've never experienced this feeling I'm feeling right now. And I said, yeah, it's great, isn't it? And she said, now I know going forward what to look for. And when I'm in a relationship with someone and they say, I love you, I can say back, I love you. So it is a synthetic, drug-induced, artificial experience. No one could say it's the same as all those years of maternal love. But for someone who's never had that feeling, what an amazing experience. So that really comes into integration. How do they use that experience in the drug-induced state to go forward and rebuild their lives? And that's a long, slow process of integration.
And I hope there will be some questions as well about that long, slow process of and how it can be supported, because that's incredibly interesting. But flowing from that, and I've only got really 2 final questions, is how are we moving into, as you always talk about this, moving away from a palliative care situation in psychiatry, right? So how are we starting to categorize and define relapse or reoccurrence? We saw with the Compass trials that the effects maybe didn't last as well as we had hoped. I see that with yours, with ayahuasca, you've seen incredibly long, depending on where people are taking it and under what circumstances. But what I'm really interested in is, how long do you think people will be needing these things? It's not a silver bullet, but we're also not creating the new Prozac. So where do we walk the line in between the two?
Well, like we said before, psychedelic psychotherapy is challenging the traditional maintenance model of psychiatry, where we treat the symptoms with drugs you have to take every day for weeks, months, years, decades, just to mask symptoms, but not get to the core. I see psychedelic psychotherapy as more like orthopedic surgery. It's a one-off, intensive, expensive, high-intensity piece of work that gets the patient better and then gets them out, and we don't have to see them again. Now, when you get your broken ankle or knee fixed, you don't expect to be going back to that surgeon every week for the next 40, 60 years. But when we treat people in psychiatry, we behave like we're palliative care doctors. Most psychiatrists are scared of the cure word. They laugh at me when I say, I think we might be able to cure people. We've become learned helpless as a profession. We don't believe we can cure. Now, and I do believe that this is the best opportunity we have. Now, at the same time, it is not a silver bullet, and we mustn't consider it a panacea, but then nor should we. And I think this is a bit unfair in terms of the level playing field. Because this is new, the eyes of the world are on us to make it work perfectly, first time, 100%. It shouldn't have to. There's no reason why we can't repeat sessions, do booster sessions once or twice a year or every couple of years, however the protocols work themselves out. So I do believe that the psychedelic psychotherapies, all of them, with whatever compound and any protocol on any psychiatric indication, do offer a new way of looking at it with intensive upfront treatment that lasts, but nor should it only be one hit or you're out. So we'll see how things go over the years. But what we don't want to do is a bit what we see with the ketamine infusion clinics, where it just becomes another regular, repetitive maintenance therapy. We want to get people better, and these drugs have the capacity to have a transformative experience that is life-changing. But you can have more than one life-changing experience.
Yeah, and to your point, we saw in the MAPS trials, 75% of the people who did not respond were exposed to new stresses. So it wasn't really a recurrence of anything that they'd previously had. In the interest of time and to open up to the rest of the floor, I wanted to just ask one final question, and if I could hear from each of you, that would be really amazing. It's a very broad question, but what is the biggest bottleneck for you in the industry right now as psychiatrists? And how can that be solved? With the final comment, is the next generation of psychiatrists available, and is it ready? Simon, if you could start, that would be great.
Is the next generation of psychiatrists ready? I don't know. I mean, so when I first started at King's, which was about 5 years ago now, I was advised not to mention any of my research into ayahuasca when I went to that interview, because it would count against me and I'd be unlikely to get the job. So I didn't. I left all of it out of my portfolio. And now there's a department of psychedelic research at King's and at Imperial and at all these different places. And if we keep going at the rate of that, then I think that the next generation of psychiatrists has to be ready. It's in the curriculum now. We have this, as psychiatrists, we have this mandatory teaching that you have to go to. And the psychedelics in that now. It's in the mandatory curriculum, only kind of a footnote, but it's in there. At least it's in there. And so if we keep going at that rate, I'm being optimistic, but I think yes. I think in 5 years' time, hopefully, as long as nothing goes really badly, we should see a pretty big shift.
Even in Australia?
I'll do my best. Yeah.
Sarah.
Well, I'm not a psychiatrist.
Beg your pardon, yes, beg your pardon.
But we are having huge problems in this country actually getting getting people to train as psychiatrists. You know, nobody really wants to be in psychiatry anymore. And there are so many shifts in how we conceptualize and understand mental health. There haven't really been any new breakthroughs in treatments for many years. The time is now for psychiatry, I say. We have big changes on the horizon, and we need psychiatrists. And I'm a clinical psychologist saying we need psychiatrists. We need to work together to understand things differently and to create, you know, take this in a new direction. There is huge potential here. It's an exciting time. And so right now, I don't think we have enough. And I think we need to do a bit of work, enough psychiatrists, that is, and we need to do a bit of work on helping people change some of their prejudices and concerns around this area. And once we do, I think it's going to be changing, real changes.
That was amazing, thank you. Ben?
Yeah, I totally agree, Sarah. I think the floodgates are going to open with an enormous amount of intensity. This is going to happen relatively suddenly in the next few years. The biggest impediment, to answer your question, is simply, well, for me, it's number of days in the week. I just cannot do enough. But it's investment and it's infrastructure. We have 2 clinics open now. We're going to have 4 clinics open by the spring. We're going to have 20 to 25 open by 2025. But we could open 10 a week. When we've got 450 people on our waiting list for the Bristol clinic the day we opened. So we could be opening 5 to 10 clinics a week and it still wouldn't be enough. Because this is such a profound paradigm shift in how we treat mental illness, and because mental illness is so prevalent, the biggest problem is quite simply supply. It's not demand. So it's just build, educate, rechange, make a completely new way of doing it, and there are plenty of customers out there for us.
Thank you, and I know you're all working hard to do so. So, any questions from the crowd? No one will take the first one. I'm happy to jump in. Sorry, Nikki, go.
What are your views on the development of new novel compounds, particularly some of the shorter acting ones, which sounds like are a bit more controversial from my gazillion-mile, 3,000-foot perspective?
I say bring it on. You know, again, we need to ensure that people get to try different things and we understand how these work. Some of them may be more suitable for some people. If we can overcome some of the barriers here to research and predominantly regulation in this country, which is a huge block to us being able to move forward, let's go. Absolutely.
I mean, this is just clever, creative pharmacology. Why not? I spoke to Rick Doblin about this 2 weeks ago in Miami, and he's we're making a 2-hour MDMA at Awaken. We're developing a shorter acting MDMA with the same entactogen qualities, but can be delivered in 2 hours. And Rick, who's quite a purist about MDMA, says you don't need that. And my answer to him is MDMA is not going away. Just because we can possibly develop a 2-hour one, if people still want the 8-hour one, it ain't going anywhere. And there's no reason why we shouldn't carry out this creative research. And it's interesting that some aspects of the psychedelic community are kind of opposing to this. They're saying, get your hands off our sacred molecules. Yet they hold up somebody like Sasha Shulgin as this tremendous pioneer, quite rightly. What did he do for 50 years of his life, if not tweak every single psychedelic molecule, take a side chain off here, methylate this, ethylate that, to see if he could even take out the psychoactivity? That was what he did, a superb creative chemist. There's nothing wrong with this. We're not going to lose psilocybin or MDMA or cannabis or DMT or any of them just because we create some new things as well. So, like Sarah says, bring it on.
I had a question, thanks. Yeah, a quick question, I guess, Sarah, to you as well. how do you think the tension between this kind of idiosyncratic, very tailored delivery of medicine versus the sort of Aristotelian phenotyping approach works out in the research side of science, and how does that kind of play through as the whole space evolves going forwards and the floodgates open, as we all hope, and all that sort of stuff?
It is a bit of a tension. So where I see it as becoming more idiosyncratic, we will achieve that by giving the people that we're working with more control, so they get more say. And the things that they're saying to us that they want to work on, so let's say you take someone with depression, they've been depressed for 20, 30 years, what's really bothering them is not necessarily just the symptoms, it's actually the things in their life that they want to be different. You know, it's very rare I see someone running down the corridor saying, have you seen my scores on the depression measure? No, they want to talk to me about, getting a relationship that works for them, the difficulty they have with wanting to have close relationships with people, but not wanting to feel so vulnerable that they end up putting people at arm's length. These are the things they need to find resolution to. And one of the things we have in research at the moment is a real pressure when you do a trial to have your outcome as, have we reduced their depressive symptoms? That's not what people necessarily want to see change. They want these other things, and we need to find new, novel ways of measuring outcomes of what we're doing so that they're more meaningful and actually speak to what our patients are telling us they want. And I think these are things that make it difficult to conduct research in this area that's showing accurately the real benefit that it can have for some people.
Actually, I have a question for the panel. So we've heard about different compounds used to treat potentially different illnesses. Is there an overlapping features between them all, or so to say? Is it really relevant to use one or another? And if so, why? What are the studies that basically, more so than the studies, what is the approach used to evaluate whether one is used? Is more effective for treating a certain illness than another. And I just want to clarify, because it could be a little bit confusing for someone that has no expertise in the field, not to know that there is a kind of like a medicine for an illness. We're used to hear that if you have certain symptoms, you take a certain drug, but whenever it becomes a little bit more of a gray area, it could be also kind of a barrier to accepting that this is just how it is in this field.
Yeah, thanks. I think that's a good question. I think at the moment, as far as I'm aware, there isn't anything that solidly suggests that one would be better. MDMA is better for depression, better than psilocybin or whatever. There are subjective accounts. So, for example, ayahuasca has a reputation of being really good for heavy lifting. So, for trauma, especially childhood trauma, things that are really difficult to get rid of. But again, I think that most people working in the field think that no matter what you take in terms of psilocybin or DMT, it gets you to the same space. What really matters is the dose. So I think that's kind of based on the fact that DMT is more potent than psilocybin, so people naturally go further when they take it. I do agree that at the moment it's a bit confusing, isn't it, which one do you go for? It reminds me a little bit of the way that we use antidepressants at the moment, where there's not really much of an indication as to who takes antidepressant. It's see which one resonates with you, which is, it's no bad thing. It's also interesting with Ben talking about developing the shorter acting chemicals. It could be if you only have, or you only want to engage in a day's worth of treatment, that you could have a very short acting chemical. Or if you want to kind of go for a much longer experience to try and lift something, you could go for iboga, which is 48 hours, or really push the boat out. So maybe that's one way that we could start dividing these things up.
Yeah, and I think just to add to that, really. Oh, sorry.
I was just going to say, I think it's a really good question, because sometimes I'm guilty of being almost too inspirational and aspirational of, it's all going to be fine and we're all going to use all of them and they all work for everything and everyone. But that's not very helpful for patients today, and I think your question's great, because patients are used to just saying, what is the drug for this condition? So in a way, we need to use our research with psychedelics to get people out of even thinking in that way. Because like Sarah said, like we've talked about, it is simply a peak experience. As Sarah describes it, it's an unusual, unordinary experience. And whether it's ketamine, psilocybin, DMT, MDMA, they are all out of the ordinary. And an out of the ordinary experience of any flavor is good for a person who is stuck for any particular reason. So we will get to the day when all of the compounds are used for all the psychiatric indications in all people, and probably in combination. And there hasn't been many proposed protocols of combination therapies. They will come, both combinations on different days and combinations within the same session. They will come, they're around the corner, but I think we're going to just broaden it to the point that it's about the non-ordinary experience, whatever the compound, and they can all be helpful for rigid mental states.
Yeah, I'll leave it there. The only thing I was going to say is it's something we've been grappling with a lot as well. And we've been investing in trying to understand if we can start to establish better digital biomarkers so we can understand, patient doing a bit more phenotyping. And so, yeah, fantastic question. Anyone else before we stop for some food and drinks?
I was just wondering, what countries are leaders in this area?
I would love to hear from you guys, but I would say the UK. And of course, the United States has been incredible. They have provided breakthrough status for 3 compounds now, which basically recognizes those compounds as having extraordinary potential to treat a specific indication. And that's provided a lot of tailwinds for the industry, but I'll let you.
I think a really, really sad way of looking at this is what are the barriers? And that comes down to individual countries' politics. And that would be a very sad situation. There's no doubt that the UK is a world-leading psychopharmacology research centre. There's no question of that. But we have some of the worst drug laws in Europe. I think we're the 3rd worst, most draconian drug laws in Europe.
Was asbestos building material when these laws were written, I think? Yeah.
It's like, that would be a very sad day if we lose our footing on the world stage in terms of psychopharmacology research because of our politicians. So it could be that the countries that start coming to the fore are the ones that have better domestic drug policies, not necessarily the best scientists and the best researchers. So that's another whole area of can of worms that we probably don't need to open, but tied intimately to a country's development of research is their domestic drug policy. So we need to tackle that as well.
And can I just add to that? We also need to look at what our existing services are. I think in the UK, we are set up to make this happen in such a good way. But unless our government does something about the regulation and allowing us to be able to do this research, we are going to be a bit stuffed. And America are going to be way ahead of us because they're working on it.
Yeah, I was getting into the actual boring legals, so we can talk about that afterwards. Does anyone else have any questions? Otherwise, I think we'll take a break. Cool. Thank you very much, Simon, Sarah, and Ben. It's always such a pleasure to see you, and even better to speak.